Good morning, everyone. Today we will be talking about the complications of rhinosinusitis. Why are we not talking about acute or chronic ease? Because actually it's a spectrum of diseases, and the acute and chronic is entirely dependent on the duration. That's why we cannot say that this is only a complication of acute rhinosinusitis. It cannot be a complication of chronic rhinosinusitis. Nothing like that. Anything can take any way. So in order to understand the complications, we need to take it as a whole. But for all practical reasons, acute complications are completely different and the chronic complications are completely different. With respect to my teachers, let us begin our today's class. Well, this is little bit confusing, maybe easy to understand for some of you, but let me explain the whole process. As we have learned in our SPM department, there is a natural course of the disease. That is, the resolution is to be taken as what is supposed to be normal, right? So, acute rhinosinusitis is less than 4 weeks. Chronic rhinosinusitis is apparently more than 12 weeks. So in order to understand that acute will anyway progress to chronic rhinosinusitis, but most of the times, this acute rhinosinusitis will resolve. That is, out of 100 times, maybe 70 to 80% of the times it will become as good as normal. With intervention, without intervention, doesn't matter. But then, will it go into chronic? Yes, maybe. Chances are there. Then, will it complicate? Yes. Any disease, remember this. If there is an acute presentation and the body does not have adequate time to adjust, it will lead to complications. So what we see is, say the 70% have gone back to normal, but 15% of the times they go in for complications, and this is more so seen in children because of their delicate nature, as in the bones are not yet completely formed and the virulence will be too high in the children. Same acute rhinosinusitis will in turn go into chronic rhinosinusitis in about approximately 5 to 10% of the times. So, what is the natural progression of the disease? We have an acute rhinosinusitis, which majority of the times will become normal with treatment, without treatment. Please remember this. Especially in children, it will cause complications. This is what is more common, and acute rhinosinusitis will convert into chronic rhinosinusitis, less common. But because of the antibiotic era and left and right use of antibiotics, the complications seen as such are very rare, but as compared to chronic rhinosinusitis, acute rhinosinusitis will cause more complications. Now, let us go see what will happen to chronic rhinosinusitis. Just like this, chronic rhinosinusitis will majority of the times go back to normal. Please try and understand. There is a difference in the thickness of the each arrows. So what does it mean? Acute, more common, complicating, common. But see here, chronic, it is less common to resolve as compared to the acute rhinosinusitis going into for complications. Two different entities, but essentially chronic rhinosinusitis as such will have more chances of going in for a resolution than going in for a complication. Please try and understand this. That is, chronic rhinosinusitis, though means some amount of surgical intervention, may or may not be intervention, or maybe a prolonged medical treatment, it will go in for a resolution. This is more important. Ultimately, resolution is the end point. But same thing, chronic rhinosinusitis, mostly will fungal origin will lead to complications. This is more so seen in adults. So the two takeaway points are either acute rhinosinusitis or chronic rhinosinusitis. They have a tendency to resolve as compared to chronic rhinosinusitis. Acute rhinosinusitis has got a chances of going in for complications. Acute rhinosinusitis may progress to chronic rhinosinusitis, but chronic rhinosinusitis complicating by itself is very unlikely unless because of the host factors, as in a immunocompromised host, or maybe the virulence is too much, something like mucormycosis, and it is seen in adults. Well then does it mean that once the complications occur there is no resolution? No. Please understand this small line. This is less transparent. That means in spite of the disease, in spite of the interventions, in spite of the complications, the body tends to heal. Please remember, body has got an inherent tendency to heal. No matter what insult you give it to the body, it will try to heal by itself. So let us see what are these complications and how to manage them further. For all practical purposes, we have divided the complications into acute, chronic, that is complications mostly because of acute diseases, chronic rhinosinusitis, or bony complications. As such, because the ENT is an integration of ear, nose and throat, acute or chronic rhinosinusitis will in turn cause either adenoiditis, some other disease like adenoiditis or eustachian tube block. As far as inferiorly, it may cause pharyngitis or even laryngitis. Chronic cough is one of the important causes or symptom of rhinosinusitis. And last but not the least, systemic complications like toxic toxic shock syndrome. This is very important because if you remember, one of the most common organisms are staph species. Staphylococcus will cause toxic shock syndrome. This has to be remembered throughout. So, one, there is a propensity for the complications to occur in winter season. Why does it occur more in winter season? It's only a matter of speculation, but essentially the incidence is more common in winter season, and acute is more common in children while chronic will lead to more complications in adults. And these, in the acute, orbital will constitute somewhere around 75%, while the intracranial will contribute somewhere around 15 to 20%, whereas the bone complications will constitute the rest. So essentially we understand that orbit will be more commonly affected, brain less next to it, and last will be the bony complications. Apart from this, because of the long-standing nature, there may be something what is called as a mucocele or a pyocele, and the rest we will see one by one now. Now, orbital cellular complications. This is a very commonly used classification. This was given by Chandler, who had grouped all the complications into 5 stages, not necessarily sequential. That is, anything can happen at any given point of time. Never there is preseptal cellulitis. After this only you should have orbital cellulitis. No, that is not the time. It's just for the understanding or easy memorization that we can have. Now, what do we mean by preseptal cellulitis? Please remember, the orbit or the globe is covered by eyelids. Eyelids are fibromuscular structures, which the fibrous part is what is called as a septum. Please brush up your anatomy of the eye, wherein this fibrous septum will medially form the medial palpebral ligament and laterally the lateral palpebral ligament. So, at times, because of the infections, what will happen is there will be cellulitis. Cellulitis is a misnomer. It is a diffuse generalized edema of the involved tissue. That means this will be something like, I'll be showing in the next slide. Okay, wait. See this. Just in front of the globe, the content of the orbit are not at all involved. So, what does this show? There is an inflammation of the area in front of the eyeball. So, this is what is called as a preseptal cellulitis. Please remember, this is unilateral. There is no edema, there is no what do we say, redness of the eye, erythema of the eye, nothing, and movements are not at all affected. So this is what is orbital cellulitis, preseptal cellulitis. The only thing what you need to remember is whether there is any proptosis or not. Preseptal cellulitis, remember, has to be differentiated from proptosis, and it has to be differentiated, and it is most of the times unilateral, because complications occur only in acute rhinosinusitis, which are usually unilateral, very rarely bilateral. Now, do we require anything further? Yes. Then there is something what is called as a orbital cellulitis, wherein the rest of the orbital contents are all swollen. Now, please remember, there are multiple factors. There is a very thin bony wall between the nose and the ethmoids and the eyeball or the periosteum of the orbit. This is what is called as a lamina papyracea. This is very thin. The virulence of the organism may cause direct diffusion of the toxins into the orbit, which will lead to orbital cellulitis. Now, please remember, orbital cellulitis, subperiosteal abscess, that is the third one, or intraorbital abscess, that is the fourth one, and the last being the cavernous sinus. All this can happen any point of time. That is, need not be happening sequentially. Please understand, cellulitis is a diffuse inflammation that is extracellular. It is not within the cell. But supposing the body is building up its own defense mechanism, what will it do? It will limit the cellulitis to one particular area. Now that area will start having necrosis, which will lead to abscess formation. So what may be an initial diffuse cellulitis will be limited by the body's defense mechanism or the healing mechanism into either a subperiosteal abscess or an intraorbital abscess. Please try and understand. This is where the sinus which affects, that will push the orbit accordingly. See, right now you're seeing the left eye. Please remember, whenever you're seeing a CT scan, you will be seeing as if you're seeing from the foot end. So in the first picture, whatever you're seeing is the midline. This is the left eye. So same thing in the second, third, fourth and fifth. So we are seeing the left eye wherein we are having left ethmoid sinuses. Say the maxillary sinus is involved, the floor of the orbit will be pushing the orbit superiorly. Very unlikely, because maxillary sinus has got an dependent drainage. More likely, ethmoid and the frontal sinus will lead to a problem in the eyeball or the abscess. That is, they will be pushing it more laterally, maybe with the periosteum, or if the cellulitis is more dependent or it is organized within the periosteum or within the orbital contents, that will make it an orbital abscess. And very rarely, if the sphenoid sinus, and more so there is something what is called as an Udoni cell. This, if it is infected, it will cause the last thing which is called as the cavernous sinus thrombosis or the orbital apex syndrome. That is, it will affect the orbital apex more commonly than the rest of the orbit. So depending on the sinus which is involved, we may have a problem, mostly because of the ethmoids. Next will be the frontal, followed by the maxilla, sphenoid, and last would be the maxilla. Why? Because maxilla is one of the strongest bones as compared to the rest of the anatomical structures which are involved. So, is this limited to acute? No. Even in cases of chronic, why will there be a pyocele or a mucocele? Because this pyocele will be, or mucocele is a cyst. That is, it's a cystic structure which is gradually compressing the bone. So it can be either in the ethmoids, frontal, maxilla, or the sphenoid. So depending on the structure, the eyeball will be pushed. The only thing what is differentiating between an acute and the chronic is the generalized symptoms of fever, chills and rigors are absent in chronic. In acute, you will always have high grade fever. Fever with chills and rigors is the hallmark of an abscess. No matter what, first thing, whenever a question is asked, fever with chills and rigors, abscess anywhere in the body. That is the dictum. Next comes malaria, tuberculosis, urinary tract infections. Those are not needed for us right now. And Last will be the cavernous sinus thrombosis. These are very important for us. And what will be the symptoms in all this? First thing, please remember, the moment any just a simple cellulitis has already started, what will it cause is, what is the function of the orbit? To cause movement of the eyeball. So there will be limitation of the eye movement. This is what is called as an ophthalmoplegia. Then, because there is an inflammation, there will be edema, there will be redness, there will be pain, that is loss of function. So what will we have? We'll have conjunctival edema, we'll have painful eye movements, because now this is all having edema, there may be a proptosis also, and depending on whether the optic nerve is involved or not, you will have impairment of the vision. Please remember, in total vision, or say any point of time we feel that we are having any problem, we need to look at two things. One is visual acuity, second is going to be eyeball movements. Both of them are there intact, nothing to worry. Any doubt, you will be having a compromise. Don't have to wait for the ophthalmologist. So how do we make out whether the visual acuity is intact or not? Visual acuity is by finger counting, and if it all needed, we have to use Ishihara's chart. Please remember, the first thing that will start to go is color blind. That is, first one, color vision is lost. Then that too, red will be lost first. Then comes the other part, that is green and blue will be lost, and then he will be seeing complaining of black and white vision, and ultimately loss of vision. Why is this occurring? Because there is an edema at the orbital apex. Now please remember, the central retinal artery is exactly in the middle of this orbital nerve. So what will it do? It will, because of the edema, it will be compressed. So now this is what is going to be more dangerous. This is where emergency evacuation, that is, the moment patient, anyone has said that his color vision is lost, you got less than 1 hour to decompress the orbit. Otherwise, he is bound to lose his color vision for permanently. So how do we manage this? Now, do we require a CT scan? Do we require a investigation, MRI? For initial stages, that is preseptal cellulitis, you're sure the eyeball movements are fine, the visual acuity is fine. Technically, you don't require. But then, how many of the times we'll be ready to wait for the complications to occur? So technically, yes, if at all possible, a CT scan, and if possible, again, MRI will be helpful. Why MRI? Because right now we are not just looking at the bony contents, we are looking at the soft tissue shadow. This is more so helpful in orbital cellulitis, or in cases of abscess, or especially in cases of cavernous sinus thrombosis. But for normal thing, to identify the this thing, bony landmarks, CT scan is the only thing required. And anything else is required? Definitely, if possible, because we are all dealing with children. Please remember, complications are more common in children. Whenever possible, try to have a sample for bacterial culture and sensitivity. This is very important, because though empirically we have a tendency to start off the antibiotics, we don't know what is the pathogen which has started all this. Is it staphylococcus or streptococcus, or is it an anaerobic infection? Because anything, or including a fungal infection, we cannot give antibiotics for a fungal infection. So So first thing is we take a sample and then start empirically on something like penicillins or cephalosporins, and then as per the culture and sensitivity report we'll be using the appropriate antibiotic. At times we may also have to supplement this with decongestant nasal drops, analgesics, antihistaminics, antipyretics, topical fomentation, and if the baby is dehydrated we need to give him hydration also. IV fluids will be necessary. So in such, this is what the investigations would be. At times even uh, gas forming anaerobic clostridium species will also cause this orbital complications. That's why MRI would be more helpful, and routine CVP will also be sent. Then do you wait for medical treatment or do you do surgical decompression? First and foremost, we are dealing with complications. Please remember, here time is of utmost importance. We have started the IV antibiotics. Ideally, he should be responding. Pre-septal stages, and all these patients, no oral antibiotics. It's strictly intravenous antibiotics. How long do we wait? Maximum is 24 to 48 hours. The moment we see that there is an abscess is only drained. There is no medical treatment for abscess unless the medical condition of the patient itself is so delicate that even if we intervene he is going to die. That's the only way we don't intervene. Otherwise, any abscess mandatorily is supposed to be drained. It's only a surgical treatment. We have given off antibiotics. We need to give him analgesics. We wait for 24 hours, maximum 48 hours. And that too, if there is no evidence of abscess. If there is an evidence of abscess, we go for surgical drainage. Then, do we drain nasally or externally? Please, again, we need to understand that whether the acuity is affected or not. Supposing if there is an visual disturbance, the patient is not having proper vision, the first thing is we need to decompress the orbit first. How do we do it? We incise the lateral palpebral ligament. How do we do it? We Please remember we are dealing with a child. He is very irritable under anesthesia. The anesthesiologist should be ready to take it out, and you have a time limit of less than an hour. You are like literally running against time. At times people have to do it on the table at bedside also. What they do is they safeguard the orbit with a small Freer's elevator and extend it more laterally, and with a 11 number blade we cut the lateral palpebral ligament exactly in the middle so that we are not damaging the upper or the lower eyelid, and go bone deep. This is what will cause the prolapse of the edematous orbital contents. There are various different methods. We need not bother. Now, if the acuity is not affected, that is, vision is intact, only a drainage is needed, then do we have an option of external drainage or internal drainage, that is Lynch-Howard's procedure, or endoscopic, remove the ethmoids, drain the sinuses. But then there is a catch. Endoscopically you can go only in the medial part. What if the abscess is superior to the orbit? or lateral to the orbit, we don't know where the abscess is going to be. So in those cases, always external on drainage and this thing evacuation procedures are much better, and they are most preferred. So we have to drain the abscess, and then at the same time, because anyway the anesthesia has been given, we have to drain whatever the sinuses that are involved, either unilateral or bilateral. As long as this is not done, our complications will not stop. The meningitis will be, I mean, the intracranial complications will be more or less similar to the orbital thing. That is, there are a spectrum of diseases wherein either because of the frontal sinus or the ethmoid sinus, most commonly the frontal, there is a breach in the inner table of the sinuses which will lead to uh, the virulent, I mean the bacteria, I mean causing cellulitis, irritation of the meninges, and in turn will lead to meningitis. If it is still progressing, may lead to cerebrum which is inflamed, that is encephalitis, at times leading to an abscess either outside the dura or inside the dura, which is called as a extradural abscess or subdural empyema. And if it is continued inside the brain tissue, brain parenchyma, it is called as a brain abscess. So ultimately, most common things what we see are meningitis and intracranial abscesses. This is essentially a clinical diagnosis, and abscesses are essentially radiological diagnosis. Meningitis, the patient will be in delirium. There will be lantern sense of sensorium, which will be associated with fever with chills and rigors. There will be high grade fever, and there will be something what is called a Kernig sign positive. Majority of the times, lumbar puncture will be helpful in identifying whether the the CSF is infected or not, and then that will also help us in whether it is viral or bacterial or fungal in nature, or tubercular in nature. And at the same time, please remember the intracranial abscesses are more commonly seen in the frontal lobe. There is no way we can clinically identify whether there is an abscess or not, except for the fact that abscess will typically present with fever with chills and rigors. But clinically, in the presence of either a thrombosis of the superior sagittal sinus or a cavernous sinus thrombosis, there is no way that we can clinically identify even with fever with chills and rigors. So essentially an imaging will be needed. If needed, both CT scan and MRI are also needed. What will happen here? There will be a high grade, with or without contrast, and this will be helpful in if it is only meningitis stage, IV antibiotics, ceftriaxone in meningitic dose, that is 2 grams per twice a day to 3 times a day depending on the age. And if there is an abscess which is readily identified, then drainage. This is what would be the most common scenario. But then intracranial will also lead to something what is called as a thrombophlebitis of the superior sagittal sinus or and the cavernous sinus. Please remember, cavernous sinus drains from lateral, the dangerous area of the face as well as the paranasal sinuses, and this doesn't have any valves in it. Apart from that, it also drains into the superior sagittal sinus. So there may be a retrograde infection, thrombosis. So what will it do? There will be severe headache with uh, focal deficits, and please remember legs will be more affected in superior sagittal sinus because these are in the, if you remember the anatomy, the motor system, motor gyrus will be having leg more in the midline rather than at the periphery or towards the temporal lobe. So that's why legs will be painful. And the cavernous sinus thrombosis, previously it was an essentially a fatal disease. That is almost 50 to 80% of the people with cavernous sinus thrombosis used to die. How do we suspect? Please remember, it is just lateral to the sphenoid sinus, and it has got the 4, 6, and third cranial nerves which are involved. So there will be a fever, there may be ptosis, that is the upper drooping of the upper eyelid will be there, and deep-seated retroorbital pain will be there, and there will be papilledema. Why should there be a papilledema? Because the venous return of the orbit is blocked. The arterial system is still working. That's why there will be papilledema, and there will be complete ophthalmoplegia. That is, there will not be any movement of the eyeballs. Why will there not be any movement of the eyeballs? Because 3, 4, 6 are responsible for the movement of the eyeballs. So the moment they are irritated or hampered, the movement will also be not be there. So how do we diagnose it? Either by MRI, most commonly by MRI with a contrast, that is in venogram. Apart from that, the treatment would be high dose intravenous antibiotics, and as early as possible drainage of the affected sinus, especially the sphenoid sinus. The systemic steroids, antibiotics, anticoagulants will be used, but please remember this is a very fatal disease, so we need to take care of the patient very well. Potts Puffy tumor is the synonym given for frontal osteomyelitis. What is osteomyelitis? Osteomyelitis is a condition of the Haversian canal. The diploic bone of the any bone. So what does this do? Because we have seen the purulent discharge in the sinuses, it is going to affect either the outer table or the inner table, which in turn will lead to a breach in the wall, and there is going to be bony necrosis, which will lead to abscess. Now this abscess will be, if it is breaching the outer table, will be leading to a subcutaneous subperiosteal abscess, which will be frontal, which will be behaving like a frontocutaneous fistula. But supposing if it is breaching the inner table, then it will lead to an breach of the inner table of the frontal sinus and lead to an intracranial abscess. So which way the abscess is presenting, that is how the whole thing will be depending. So the moment a frontocutaneous fistula is created, this is what is known as frontal, Potts Puffy tumor. So how do we do it? This is going to be, it's intravenous IV antibiotics. IV antibiotics, and also curettage of the bone. And most commonly, external drainage is what is more this thing required rather than internal, because frontal sinus is we can reach the ostium of the frontal sinus endoscopically, but we can never reach the superior part of the frontal limit. So that's why outer table and inner table, in order to reach it, we need to go externally. That is, osteoplastic flap technique has to be inserted, and a proper drainage has to be done, and so that there is no recurrence of the sinuses. So all these endoscopic procedures will also be secondary to uh, what do we say? The people who are now doing endoscopically also, but then the techniques are very, very complicated. Something like DAF type 1, type 2, and type 3, which are which require a quite amount of skill. But then we don't have that much of expertise for everyone. So osteoplastic flap is what is most commonly affected. Systemic will include toxic shock syndrome, which is a staphylococcal infection wherein there will be a release of the toxins into the body and will lead to necrosis of the skin and the underlying tissue. So essentially all this will be maximum a 4 marks question. Cavernous sinus thrombosis may be a 2 marks question for you. Orbital cellulitis and the different stages will be at the most a passing reference, that is a 4 marks question. Beyond that, more importantly, this will be asked in case of practical exams, viva voce, or during your case presentation. What are the different techniques and all that will be used? So this essentially finishes our infections of the lateral wall of the nose. Next class we will be dealing with different types of rhinitis. This is again a big issue. I mean, big topic. Let us go one by one. Thank you.